all this lecture about cerebral aneurysm and subarachnoid hemorrhage, diagnosis and management. Dr. Shazim Hussain, a professor of neurology, faculty of medicine, yes, Cleveland College. You can start, Dr. Shazim.
Great. Well, thank you very much for the invitation, and very happy to have a chance to talk to you, as well as hopefully we can have some questions and discussion at the end. Today, as mentioned, I'll speak a bit about cerebral aneurysms and subarachnoid hemorrhage, talking about some of the ways that we manage these patients, and as well as some of the things that are on the forefront of what we're seeing developing in the field. These are my disclosures, and I also wanted to thank Dr. Nina Moore and Dr. Pravin George, who helped me with some of the slides for today's presentation. And so what I'll try to go through in the next hours to understand the factors related to aneurysms, formation and rupture. We'll talk a bit about the management of subarachnoid hemorrhage, as well as highlighting some of the treatment options for cerebral aneurysms. So intracranial aneurysm, to start off with, it is actually not uncommon. If you do scans on everyone walking around, about 3 to 5% of the population actually have a brain aneurysm. Fortunately, their overall rate of rupture is actually very low. It's less than 1%. However, if it does rupture, then it can cause subarachnoid hemorrhage, which, as we all know, can have very devastating consequences. About 50% of people who have a subarachnoid hemorrhage will pass away. And of those survivors, the 50% of those survivors will have substantial disabilities. So if there are ways to prevent subarachnoid hemorrhage, these are usually good strategies. And that comes in twofold. One, we should really be looking for how we can prevent aneurysm formation in the first place. And then as well as when we find aneurysms, how can we do better to treat these aneurysms? Just to talk a little bit about how cerebral blood vessels are a little bit different than other blood vessels of the body. It really comes down to the layers of those blood vessel wall. In general, a cerebral blood vessel will have a thicker internal elastic lamina, but they do have a decreased proportion of elastin fibers and smooth muscle cells, as well as having a thinner adventitia. What this means in the long run then is if an aneurysm forms on these blood vessels, it tends to be more fragile than it will be in other locations. Now, in terms of aneurysms themselves, those cerebral aneurysms, how they form and how they behave, it actually is still something that is not well understood and the subject of a lot of research. What we do know, and you can see there on the picture of different locations, the common locations, we see these brain aneurysms. They are found in usually typical locations at bifurcation points, as well as those areas where there's an angulation to the vessel. And that probably has to do with how the blood is hitting the wall of the blood vessel and creating something called the wall shear stress. We do talk about classic risk factors in this situation, things like family history of brain aneurysms or subarachnoid hemorrhage. If someone is a smoker or if they have high blood pressure, these are things that can be a risk for both aneurysm formation as well as aneurysm rupture. But ultimately, this is a really complex interplay between endothelial dysfunction, inflammatory responses, as well as flow dynamics. Just to spend a minute on the genetics of things, of course, we do know that aneurysms can run in families. If you have one relative, this is about a twofold increase. If there's two relatives, that portends a fourfold increase. Now, the exact genetic signature has remained elusive. There have been some particular gene loci that have been looked at, related mainly to gene coding of elastin and collagen. We do know of also unknown conditions that can predispose, things like autosomal dominant polycystic kidney disease, Ehlers-Danlos, fibromuscular dysplasia, as well as Marfan syndrome. So these are all conditions where if someone has those conditions, they have to be screened for brain aneurysms because they happen in very, very high frequency. Now, in terms of aneurysm rupture, we know that there are certain factors that do create an increased risk. This is larger size, posterior circulation aneurysms, those in the ACOM or PCOM locations. those of a regular shape, as well as those who have daughter sacs. All of these factors, if you see these in a brain aneurysm, will increase your likelihood of that aneurysm being potentially risky to the patients. And why does this happen? Well, we think that aneurysm rupture is really the final stage of the degradation of that vessel wall, the inflammatory process that's going on in these wall of the blood vessels hit a critical point where the wall is now thinned, and actually low shear stress at the dome may portend a higher risk of this rupture occurring. Just another factor that we really should be paying a lot of attention to is that of smoking. This is a very strong risk factor for aneurysm, both aneurysm formation as well as rupture. It interacts with the blood vessels, the nicotine primarily, but it has a variety of mechanisms. That's hemodynamic stress on the blood vessels, reactive oxidative species, endothelial dysfunction, as well as increased inflammation. Really, essentially, it actually affects every step of aneurysm formation and rupture. So if there's one thing that we can have our patients do and have people in society do that would help to reduce our risk, is really to get people to quit smoking. In terms of aneurysm prevention, the other things that we talk to patients about are of course, treating high blood pressure. High blood pressure, if it's uncontrolled, can be a high risk. We talked about the smoking aspect. Aspirin is actually a very interesting story because of the role of inflammation in the walls of these blood vessels. There's some reasonable data that suggests that patients who are on aspirin actually have lower risk, if they also have an unruptured aneurysm, have a lower risk of subarachnoid hemorrhage. So if someone does have a brain aneurysm, and in particular if they have another reason to be on aspirin, I think it's a very good strategy to have these patients take a baby aspirin once a day. Statins, also we know the beneficial effects, the reduced inflammation we can see with statins. However, when this has been studied in humans, they really haven't shown a specific benefit there. There are also multiple other therapies being currently investigated which attack those inflammatory pathways. Okay, well, just again, that was a brief overview about aneurysm formation and development. We'll go into next, just going to a little bit of a case example to help us to understand how we might approach subarachnoid hemorrhage. So imagine a patient, a 41-year-old female who had no medical or surgical history. They're brought in by the emergency room by ambulance with a really intense headache, really severe headache. Oftentimes we'll describe it as the worst headache of their life, as she was just going about her daily business. She was giving a presentation. She then had a sudden loss of consciousness, but was alert and oriented by the time she comes to the emergency room. And of course, in that situation, the emergency room sees the patient and gets our neurologist consulted, and we order a CT scan of the head. And this is what we see on our CT scan. We see here evidence now, if you can see my pointer here, you can see in the fissures of the brain, the subarachnoid space here, this very hyperdense signal, which is basically blood products sitting in the subarachnoid space. The other thing we're noticing is that there's generally, the brain looks quite full. We're not seeing a lot of the sulci here. And also, if we look at the ventricles, these ventricles are enlarged, so there may be early developing hydrocephalus occurring in this situation as well. So the question is, what do we do next? Well, hopefully we're not going to be in a situation where we panic. We have good strategies of how to deal with this situation. Talking first of all, when you see that patient in the emergency room, what should alert you about the possibility of presenting signs of a subarachnoid hemorrhage? Usually, again, this headache is a whole head headache, and people describe it as a very severe headache, often described as the worst headache of their life. And this is even in people who have potentially, for example, severe migraines, they get really bad headaches. If they experience a subarachnoid hemorrhage, they will tell you that this headache is completely different from any headache that they've ever experienced. Important to look for that in the history, as well as to look back and see if they had any prior history of headaches as well. About 10 to 40% of patients will have a warning leak or something called a sentinel headache. And typically this will be the 2 to 8 weeks prior, but this is basically where there was a tiny leak of blood, which can also create that really intense severe headache. In addition, because of the irritation that goes on with the meningeal structures, as well as the high intracranial pressure that can result, people will sometimes experience nausea, may have vomited, they may have photophobia, real sensitivity to light, stiffness of their neck, as well as, of course, if depending on where that subarachnoid occurred and if it's actually affecting the brain tissue itself, for example, an aneurysm that ruptures and causes a little bit of an intraparenchymal hemorrhage, you can also have focal neurological deficits, as well as transient loss of consciousness and altered mental status. So a really wide constellation of symptoms, but those patients were presenting with focal neurological deficits, or altered mental status, but also experiencing that worst headache of her life. Really important to make sure that you're alert to the possibility of a subarachnoid hemorrhage and get imaging done right away. Okay, so now we have the CT scan. We know the patient has a subarachnoid hemorrhage. What are we going to do at this point? Again, we're hopefully not going to panic. We're going to be able to get into our ability to make sure that patient's stable and get the care that they need. And so first thing, as we do with all patients, make sure the patient is stabilized, making sure they have a protected airway, that they're breathing, their circulation is intact, and making sure we're all doing all the other surveys that are necessary. Very, very important, because patients also can, have a wide range of how they present. In this case, this patient is awake and alert, but oftentimes they will come in comatose and may need to be intubated for airway protection. Typically at this point, we'll also want to make sure our neurosurgical team has been consulted or involved in the care of the patient. And as well, typically these patients are going to, regardless of how good they look in the emergency room, you really want those patients in an intensive care unit. If they're available to you, a neurological intensive care unit where providers and the team have expertise specifically in neurological conditions is also very, very valuable. In addition, the really immediate first steps that we want to talk about are making sure we're controlling that blood pressure, making sure we have seizure therapy on board, understanding the grade of that subarachnoid hemorrhage, which may help us with some of the decision making later on, getting some kind of imaging, vessel imaging, because we need to understand if there's an aneurysm and how we might approach treating that aneurysm, and then the management, of course, of hydrocephalus. So let's go through these quickly. Starting off with controlling re-rupture. Re-rupture can be a very devastating condition. If an aneurysm has ruptured and caused subarachnoid, a re-rupture is often fatal. Typically, a re-rupture will happen most likely in the first 48 hours after an aneurysm has ruptured, and so which is why we want to secure that aneurysm as soon as possible. In the meantime, while we're waiting for the team about how we're going to secure this aneurysm, really important to get that blood pressure under tight control. We usually aim for a target of getting that systolic blood pressure less than 140 millimeters of mercury. Although, if you look at the evidence, it's a little bit tricky to know exactly what that blood pressure target is, but getting under 140 seems to be a good target to make sure that we're going to avoid this re-rupture. There is an agent called aminocupritic acid. This was actually studied and did show a reduction in re-rupture. However, there was an associated increase in the risk of DVT and ischemic strokes as well. And ultimately, when they looked at the data, it did not improve outcomes. So in general, unless this is a type of aneurysm that can't be secured in a very, very quick manner, within the first 24 hours, typically we won't utilize this particular agent because of the other potential side effects and risks to it. Now, in terms of seizures, we should recognize that seizures can occur in up to 20% of subarachnoid patients. Of course, seizures can be very dangerous in this situation, particularly if you have an unsecured aneurysm. As that aneurysm, seizures can produce hypertension, which can potentially cause that aneurysm then to re-rupture. Overall, there's not, a lot of evidence in terms of clinical data that actually suggests which agent or which patients may need anti-seizure medications. However, at Cleveland Clinic, what we've utilized is the strategy of using at least 3 days worth of prophylaxis. That covers you in that immediate period where we're trying to secure the aneurysm, as well as the immediate post-operative period. Usually we use the agent called Keppra, which is, we feel has a favorable side effect profile. And really, again, it's the main thing here is to minimize that risk of seizure in the acute setting, where there can be an increased re-rupture potential. Okay, so shifting to the grading of a subarachnoid hemorrhage, there's different scales that are available. We particularly use the Hunt and Hess score, and you can see the scoring ranges from 1 to 5, 1 being a very, very mild headache, where a patient's completely alert and oriented, down to 5, where a person is comatose and having very, very severe neurological symptoms and deficits. The reason why it's useful to have this Hunt and Hess score is that this score helps you to then predict what the mortality of these patients might be, and also potential disability. You can see there on the right-hand side of the screen the different mortalities, where a 1, although mortality can still occur, generally speaking, that's a pretty favorable outcome, versus a grade 5, where it's a very, very likely that 90% of these patients will actually go on to pass away. Now, this we have to also be a little bit cautious, though, of not having a self-fulfilling prophecy. A lot of times, these patients who do show up severe, with effective management of their condition and avoiding complications, we actually have seen some patients who are grade 4 and 5 have a reasonable clinical outcome. So sometimes we're in the situation where they come in very severely and where a decision is made not to treat these patients, and of course then they won't do well. But more and more evidence is coming out that potentially if you treat some of these patients, that they may actually have a reasonable outcome. And the challenge for us as providers, as physicians, are to sort out which of the patients that might benefit, so we can be definitely more aggressive in those situations. Another useful thing to look at when you're assessing a patient with subarachnoid hemorrhage is how much blood is on the scan itself. There's a useful scale called the modified Fisher grade, and this ranges from 0, which would be no subarachnoid hemorrhage, going through grade 1, 2, 3, and 4. 4 is one which has really, really focal diffuse ICH. So grade 1, you can see here on the panel here, very small amount of blood, nothing in the ventricles. If we start to get blood into the ventricles, you can see here the fourth and lateral ventricles, but overall it's a fairly small amount of blood, and we consider that a grade 2. You can see here a very, very large amount of blood on the scan, but nothing inside the ventricles, which would give us grade 3. And then again, a large amount of blood coming into the ventricles as well would be a grade 4. Again, reason why this is useful is that this can help us actually predict the vasospasm risk, whereas the higher the grade 4s can have up to 40%, even potentially 50% risk of having vasospasm in the course of their hospitalization. Vessel imaging also very, very useful in the setting of subarachnoid hemorrhage. Of course, there are other reasons why subarachnoid hemorrhage can occur, for example, head trauma, but this allows us to establish that this is an aneurysmal subarachnoid hemorrhage, which has a certain way that the patient will potentially have their clinical course as well as potential complications. We utilize different techniques. MRA and CTA are often used as a useful screening tool. MRAs usually can detect aneurysms down to about 3 millimeter size. CT scans, probably because of their resolution, can actually detect aneurysms down to about 2 millimeters. So are a very, very useful test in this particular setting. Of course, our gold standard of detection is that of the cerebral angiogram, or DSA. This allows us very, very detailed anatomic data about that aneurysm, as well as providing the flow dynamics of the aneurysm, and ultimately gives you a lot of detailed information about how you can potentially treat that aneurysm. In this setting as well, most aneurysms now, 90%, are treated with endovascular techniques, and so we get good detailed visualization of the aneurysm, and most of the time during that initial angiogram test, we can actually go on and treat that aneurysm to secure it. And I'll come more into the treatment options of cerebral aneurysms in a moment here. Looking at managing hydrocephalus, remember that cerebral spinal fluid is something that the body continuously produces. There really is nothing that can stop its production, although we do have agents that potentially can slow that down. With every heartbeat, the way that the CSF system is that will actually create more CSF. And therefore, if you have then problems with the blood blocking the drainage pathways for that CSF, very quickly a patient can develop increased CSF in the intracranial space, which is a condition known as hydrocephalus. It's estimated that probably about 20 to 30% of patients with subarachnoid hemorrhage will develop hydrocephalus. Usually, this will initially present in the first 48 hours. And so it's important to be, aware of this, see for any clinical sign of increased intracranial pressure, looking at your scans to see what kind of evidence there is potentially of enlargement of the ventricles, and then potentially we have methods, of course, to treat hydrocephalus. Initially, that usually is the management by the potentially placement of an external ventricular drain. And then, this will be managed through the course of the hospital stay. We want to, of course, drain off CSF to allow blood products to, be drained out and hopefully clear some of that blood out of the CSF space. As well as that, as the course of the patient goes on, and we think that the drainage might be a little bit better, you can raise that EVD to get to a point, hopefully, where that EVD can be discontinued in the majority of patients. However, about a third of subarachnoid patients may require some kind of VP shunt, which then can be placed in these particular situations. Just to comment a little bit about vasospasm and delayed cerebral ischemia. Vasospasm, it can occur, it actually probably occurs in the majority of aneurysmal subarachnoid hemorrhage, about 70% of all patients. We talk about a time window for vasospasm. Usually this will start 3 to 4 days after the start, peaks at around 7 to 10 days, and then resolves by 21 days. And then the other concept in all this, when we talk about vasospasm, we talk about this delayed cerebral ischemia. And now delayed cerebral ischemia is the situation in aneurysmal subarachnoid hemorrhage when you have focal neurological deficits develop. And again, this usually happens between day 4 and 14 and is often the major cause of death and disability in these patients. Now, an important thing to understand here is that vasospasm does not cause, per se, delayed cerebral ischemia. There's actually probably a variety of vascular and other changes that are occurring after subarachnoid that are going to cause delayed cerebral ischemia. Delayed cerebral ischemia can happen without actually patients having angiographic vasospasm. It can occur in territories that are outside of angiographic vasospasm. And interestingly, in trials that look and actually are very, very effective in stopping vasospasm, oftentimes we don't see that effect in actually preventing this delayed cerebral ischemia. So this is something that we have to be cognizant of, because we may be very, very aggressive in treating vasospasm, but we have to be mindful that there still are other reasons why this delayed cerebral ischemia can occur. Now, when we talk about delayed cerebral ischemia and how we can prevent it, the main agent of choice is an agent called nimodipine. This is the only agent that has level 1 class A evidence of a therapeutic benefit in subarachnoid hemorrhage. This is a calcium channel blocker. Originally, it was mainly thought its mechanism of how it helped in this situation was the help with vasospasm. However, it really also delays the risk of delayed cerebral ischemia outside of its effect on vasospasm. And so it's very, very interesting that primarily it seems to have its effect more not on the blood vessels itself, but it's something to do with the delayed cerebral ischemia. The other important thing to talk about is that we were taught, a lot of us, certainly when I was going through school, we learned about this triple H therapy: hemodilution, hypertension, and hypervolemia. Actually, as we've studied this in more detail, we find that this really is not necessarily all these H's. All of these don't necessarily work, and actually can increase morbidity and mortality. Particularly, it seems to be the hypervolemia piece, that increasing a patient's blood volume may actually have a lot of detrimental effects. And so nowadays, we're actually aiming more for euvolemia in these situations. We do certainly try to make sure we are keeping the patients hypertense. That seems to be something that can reduce the risk of delayed cerebral ischemia through probably improving circulation at a microcirculatory level. And then if there is some vasospasm, certainly utilization of angiography, as was a vasodilator therapy, and even balloon angioplasty can be useful if the hypertension and hypervolemia are not necessarily helping. So. Monitoring wise, what do we do for monitoring? Well, the tried and true method that most people utilize is that of transcranial Doppler. Of course, you have to have some experience with transcranial Doppler. This can be very, very operator dependent, but is a very, very good technology because it can be widely available and people can be trained up on it fairly quickly. And I know Dr. Secor is with us and is a much better expert in transcranial Doppler, so perhaps he can also comment on this at the end of my talk. We are actually utilizing this at the Cleveland Clinic and can be, fairly sensitive and specific if done by experienced operators and understanding kind of exactly where those targets should be. EEG is another tool that some have advocated for to detect vasospasm. This is probably, I would still say, an experimental phase, as there are AI techniques, ways we can analyze the alpha and delta ratios and other aspects of the EEG that might be able to help predict vasospasm down the line. CT and MR perfusion potentially could be utilized, but oftentimes in a very sick patient, of course, this can be a very difficult test to obtain. Moving a patient who's sick in the ICU to radiology areas to get CT scans or MRI scans isn't an easy task for anybody who's dealt with these patients. The gold standard of this does still remain to be cerebral angio, the clinical exam. You want to make sure you're keeping a close clinical eye on the patients, and if you are seeing the development of focal neurological deficits, This is usually a high clinical suspicion then that this is probably related to vasospasm and delayed cerebral ischemia. Of course, though, we are limited in these patients where, for example, high-grade subarachnoid hemorrhage patients, when they're already comatose, it may be difficult to get a good clinical exam. And so other tools that can help us to assess the brain function are really, really needed. And hopefully with the research that's going on right now, something will become more available in the near future. So overall, when you talk about aneurysmal subarachnoid hemorrhage, I think that it's important to make sure we're setting goals. If you're in your particular institution, talk it over with your teams and set those specific goals for blood pressure and volume status after intervention. Therapy, the other complications that can occur in this situation are things like DVTs and pulmonary embolus. So sometimes we have to think about how we're going to do anticoagulation in these patients. Good news is that usually once you get that aneurysm secured, you can often proceed with whatever other therapies those patients need for their care, including anticoagulation. Oftentimes these patients are spending a long time in our ICU units. They're basically you're bed bound, not allowed to move around. And all with that can become a disuse, atrophy, and other neurological complications. And there's a lot of good evidence coming out that mobilization after subarachnoid hemorrhage can actually prevent a lot of these complications, as well as make sure those patients are retaining a lot of their function that they're going to need for, the rehabilitation phase. And then certainly there are a lot of new therapies, which I'll come into next, especially for wide-necked aneurysms that help us more and more to treat these patients with the less invasive techniques. Okay, going back to a kind of aneurysm, let's talk a little bit about the treatments that we can offer for brain aneurysms at this point. Wide range of treatments that are available. If we talk about broadly for unruptured aneurysms, certainly conservative management, which means following these patients with imaging, is a reasonable technique, particularly if you have very, very small aneurysms. However, of course, in the setting of a subarachnoid hemorrhage, this is not really going to be an option. When we talk about definitive therapy, we of course have the open surgical technique, which has been around since the 1950s, clipping of aneurysms, and certainly in certain types of aneurysms, this is still a very, very good technique to treat brain aneurysm. However, endovascular therapy really has emerged as likely the first-line therapy for most brain aneurysms, particularly in the study of subarachnoid hemorrhage, when open surgical therapy, not only are you dealing with the complexities of trying to deal with the brain aneurysm with open surgery, but you're also dealing with a situation where the subarachnoid hemorrhage has caused a lot of inflammation and other changes in the brain that can make it sometimes very risky to do an open surgical treatment. This is from the unruptured aneurysm trial. Just to highlight that, we do, again, as we commented on, know that aneurysms of different sizes and depending on their location do have different risks of rupture. I'll also point out that when you look at this study, you see that this group 1 in the anterior communicating middle cerebral or internal carotid at under 7 millimeters of size was sitting at a 0%. This is without previous subarachnoid hemorrhage. Of course, we see aneurysms less than 7 millimeters quite frequently that have ruptured. So the likelihood that this is actually 0 is pretty low. However, one also has to be mindful that we don't actually know what the denominator is here. There are likely a lot of very, very small aneurysms out there that people live a long, normal, healthy life and never ever have a problem with subarachnoid hemorrhage. So we have to be a little bit careful not to jump into the trap of having to treat every small aneurysm because we worry that their aneurysms will always rupture. So the vast majority of these small aneurysms probably are less likely. And again, an area that's subject to much research right now to understand who are the patients that we can watch, and hopefully are there ones in there that maybe there's other factors. And this is where flow dynamics, AI may also help us as well to better understand which of the patients we can actually treat and which are the ones we can observe. Again, in those cases of conservative management, we're looking for growth or change over time. If we do see that change or growth, those will be patients that you do want to treat. This is, again, talking about the unruptured aneurysm population. Of course, surgical clipping, tried and true technique, but more and more now we talk about endovascular therapies. Coiling has now been around for 30 years, so this has been shown to be a very good and durable treatment over time. And we'll come into, there's many, many new devices that we can actually utilize to help us to take great care of these patients. For subarachnoid hemorrhage, the main trial that we utilized to decide about treatment was this ISAT trial. This was a trial looking at patients with subarachnoid hemorrhage who were randomized to either open neurosurgical clipping versus endovascular therapy. You can see here from the overall mortality standpoint that more patients passed away from the clipped group to about 31% versus only 24% in the coiled group. And then if you extend out to the 1-year mortality, again, a little bit less in the coiled group versus the clipped group all over time. And so with this data, this is primarily what has driven us mainly to treat with endovascular therapy for any patients who can really benefit from that situation. Now, of course, those of us who deal with brain aneurysms know that there's a lot of brain aneurysms that actually can be very difficult to treat endovascularly, particularly in the past when we had these wide-necked aneurysms, ones that have a very, very large base, where you can imagine that situation if you were just simply to try to put coils into that aneurysm, they may want to fall into the parent artery, which can occlude it and then cause a lot of problems with strokes and neurological deficits. Fortunately, over the years, there's been a lot of great technological development in this situation. It started with balloons and stent therapies, where we could basically put a balloon up, have a coil, a catheter inside the aneurysm, which we can then coil, and that balloon then would help to support these coils as they formed a stable mass inside that aneurysm, so you could occlude these wider necked ones. Stents were also a great step forward, where these very, very flexible stents that were designed for the brain circulation can be put in. You can see here in a schematic where the stent is there and you put the catheter in, then coil. Of course, stents in the subarachnoid setting are a little bit more challenging, because then you do require having to put a patient onto blood thinners in the setting of someone who's had recent bleeding in the brain. Therefore, oftentimes in the subarachnoid setting, we were doing more balloon treatment. And if we got a stable mass, potentially would have to bring the patient back later once they were through their recovery after the subarachnoid hemorrhage to finalize the treatment of the aneurysm with stents. You can see that there was really elegant ways that these stents were being utilized. This is something called a Y-stent configuration, where this is a wide-necked bifurcation aneurysm. You could put a stent into both limbs of the blood vessels that were taking off near the aneurysm location, providing that stable scaffolding to allow you to then coil the aneurysm. And this is an example case here. You can see markers of the stent here. This is the other end of the blood vessel over here. And in the center, then you can place your coils, occluding that occluding that aneurysm with the coil mass. Again, a situation where without this technology, unlikely that you would probably be able to treat this kind of brain aneurysm. Now, moving forward now in the recent 7 years or so, 5 to 7 years, we really have come into this area of flow diversion. And we have these new flow diverting stents. You can see here what a traditional stent looks like and what its meshwork is. These stents you can see here are tightly woven with this very, very fine braid, so that those spaces between the stent struts are very, very small. And what this allows then, you can see how flexible that is as well. You can twist it into all kinds of different shapes. What this allows is us to be able to then redirect the blood flow. Once you put that stent into the artery, it disrupts that flow jet, keeps the blood flow in the main artery, and then the aneurysm will thrombose. As the blood body heals around the stent, that those aneurysms are then, the aneurysm is then excluded from the circulation. You can see here the nice thing about these different stents as well is that they have different, they can actually be modified depending on if you pack them in more closely. Once you have the one end anchored, you can pack the stent in and get a very, very tightly compacted stent, versus other areas where you maybe want to have it a little bit unpacked because you maybe have perforating vessels. You can actually change that with the size of the blood vessel and how much you're packing into it. Nice example case here of a 6-year-old with headaches and ophthalmoplegia, very, very large aneurysm. Again, this would be one that would be very, very challenging indeed from the surgical perspective. In addition, from the endovascular perspective, oftentimes very difficult, even with basic stent technology. And often the usual solution to this was a test balloon occlusion, and then potentially having to sacrifice the blood vessel. You can see here, this is, we're working on getting these catheters up, and inside here is the stent that we're going to deploy into the blood vessel. Here you can see the shadow of the flow diverting stent that we put into the artery. And hopefully you can see that snake going through there. And you can see as soon as this has been placed into the blood vessel, you can see a lot of stagnation of contrast into that artery, into that aneurysm. That's a very good sign that that aneurysm is going to go on and thrombose and have a very nice result. And this is a picture then from 1 year later, which shows really exclusion of that brain aneurysm off of the scan. Another very, very nice case here showing what this technology can potentially offer. A 33-year-old female who was a smoker, found that she was having a lot of retroorbital headache and diplopia, had a very large aneurysm in her posterior circulation. Again, very, very challenging location, not a location you typically operate on, and our existing techniques for treating these kind of aneurysms very, very challenging. Very, very, very large basilar aneurysm and no significant PCOM contribution to that posterior circulation as well. One technique that was utilized if you had large PCOMs, one could consider sacrificing, although again, very, very high risk of that situation of causing a lot of morbidity and mortality. Instead, what was done there was a flow diverting stent, and hopefully you guys can see the outline of the stent here. And I'll put up some blue marks here to help showcase where that is. And you can see as soon as that flow diverting stent is put into place, really reduced blood flow going on into that cerebral aneurysm. Very, very late phase, you can see the venous sinuses here. You can still see filling of the aneurysm, but it's stagnating quite a bit. And you can see here when they brought the patient back, even on day 5 afterwards, you can already see that that aneurysm has been excluded from the circulation. And this particular patient then on a 6-month follow-up really, clinically came back to normal. Did have the occasional diplopia when she looked towards the left, but essentially was back to normal. And really, again, a type of aneurysm, high morbidity and mortality to treat in the past. Now with these flow diverting stents, we have a lot more clinical options. Again, just a comparison, this was a 6-month angiogram. You can see there in the lower corners what the aneurysm looked like before and seeing what it looks like at current state. And then we also now have these techniques of using intrasaccular flow diverters. The first of which is a device called the Webb device. I can see here it essentially looks like a little cage ball that you can put inside of the aneurysm. And at the base of the aneurysm, there's a tight weave. Excuse me. This allows us to that the blood as it comes up then the flow will be redirected away from the brain aneurysm and into the main arteries. And this again is a nice, very, very nice techniques for these bifurcation aneurysms that have a wide neck. This is an example of an anterior communicating artery aneurysm. Again, you can see how wide the base of this aneurysm is. Imagine that you were trying to put coils into this, very, unlikely to be able to keep those coils in place. They will want to fall into the main artery. One could try a Y or X configuration to some stents to kind of create a scaffolding for that. But in this case, they chose to use a Webb device. You can see here, this is the deployment of that Webb device into the brain aneurysm. You can see as soon as it's even deployed, all the stagnation of contrast that's occurring, so that it's already working to kind of keep that blood flow away from the aneurysm and keep the blood that was in the aneurysm that's going to thrombose off. You see again very quickly it can exclude the aneurysm from the circulation. There is some interest in what these will do over time. We can often see them compress and change their configuration a bit if we do follow-up angiography. Sometimes to the point where there can be a little residual aneurysm at the neck, but overall it seems to be quite a nice technique for treating brain aneurysms. We also have other newer devices, braided, coil-like flow, who have a property of both a coil as well as a flow diverter, and so a lot of these devices should be available in the near future. And just to wrap up, I just want to show a couple of interesting things that we're doing here at Cleveland Clinic. The technology for 3D printing has actually come a long way, and these can be very, very useful in the situation of cerebral aneurysm. See here my partner, Dr. Bain, who's using the flow, this 3D model to visualize how he's going to treat this particular patient, and actually helps with patient education as well. He's doing this now in the operating room. He's educating the resident team, being able to help them visualize a little bit better of what's going to happen with this particular clipping case of the brain aneurysm. We're also utilizing something called 7 Tesla MRA. The 7 Tesla is a very, very strong field strength for a MRI scanner. And as you can see from some of these pictures, the quality of these images is really coming very close to rivaling that of catheter angiography. So you can see the angiogram here with a small AVM from the choroid plexus, which we actually make out quite well on the time of flight MRA. Again, here's a catheter angiogram. You can see here a standard, this is a 3 Tesla MRA. You get, a reasonable quality on it, but once we get the 7 Tesla, we can really make out a lot of detail, including, here is the ophthalmic artery coming off of the blood vessel. So really, really nice resolution to these 7 Tesla scans. This is a case that I really like because it's a very, very complex AVM. And the nice thing here is we can actually see the perforators coming through the brainstem and going to this nidus of the AVM. This is something we may not necessarily, on a standard MRI, you certainly wouldn't have been able to appreciate. Even on catheter angiography, you have to correlate it, of course, to your knowledge of the brain structures, but seeing it and visualizing it this way really can help give you a lot better understanding of what this AVM looks like. This is just a 3D rotation, so you can see the quality of that picture based on that 7 Tesla MRA. Again, compare that to the angiogram. It's really coming close to rivaling angiography, and may be able to be utilized as a non-invasive way to study these brain lesions. So hopefully I've left a bit of time for questions, but again, just wanted to highlight a little bit about aneurysm formation and rupture. Hopefully we've been able to go through and understand that subarachnoid, while it can be a very devastating condition, if we are aggressive about our critical care measures, as well as proactive in the management to avoid complications, we can see patients recover and have good outcomes. Again, very, very good options now exist for the treatment of brain aneurysms, particularly on the endovascular side. And that new device technology is going to continue to drive more and more aneurysms, more and more endovascular treatments, especially as we deal with those challenging wide neck aneurysms. And with that, I really, again, thank you for the opportunity to speak to you guys, and happy to have some questions and discussion.
Thank you very much, Doctor. Thank you to all. Anyone have any question, you can type it in questions.
I think I see some questions in the chat about autonomous. Go ahead.
The question and answer. We have 2 questions.
Okay. Do you want me to just read them out, or? And the first question was, what should be the difference in blood pressure goal before and after securing aneurysm for subarachnoid and lobar hemorrhage? Very, very good question. In general, when we talk about subarachnoid hemorrhage, again, the data is a little bit, it probably would be useful to get a little more clear data, but presently in most of the guidelines around the world, they advocate for using a systolic blood pressure target of less than 140 over 90. For subarachnoid hemorrhage. This is before aneurysm is secured. For lobar hemorrhages, the general guideline would point towards less than 160 over 90, although there may be some evidence that dropping even to lower targets to less than 140 might be beneficial, although the data is a little bit conflicting. With that, I think if you're shooting for lower targets in the intracerebral ICH patients with brain bleeds, you just have to be careful about understanding what the vessel status. What we found when we tried to shift to lower targets is that we had some patients that actually ended up having, because they had carotid stenosis, for example, dropping their blood pressure because of the disruption of autoregulation. They actually ended up with more ischemic infarcts in the setting of these acute conditions. So in general, for subarachnoid, we use the target of less than 140. for ICH less than 160, but in selected situations, you could potentially get more aggressive. Once the aneurysm is secured, at that point for subarachnoid hemorrhage, it's actually better to let the blood pressure drift up higher, utilizing blood pressure targets of systolic blood pressure. You want to keep it on the higher range, and less than 220 is what we use as the target there. The higher blood pressure there probably helps to reduce the risk of vasospasm and potentially delayed cerebral ischemia. Next question I have in the chat. Since cerebral spinal fluid is found in this arachnoid space and passes through the brain ventricles in subarachnoid hemorrhage, blood is assumed to reach the cerebral ventricles, and will we see it in CT and MRI imaging? In terms of blood in the ventricles, that largely depends on the severity of the bleeding, and how much blood is collected in those different spaces. So oftentimes you will see blood inside the ventricles. There may be true that, as you said, the blood is mixed in with the CSF and is circulating around. So it is quite possible that at a microscopic level, you'll see blood cells in that area. Whether or not it reaches a state where you can actually visualize on a CT is a good question. However, the main thing, remember also the way that it's causing problems with the drainage is through the final drainage channels into the venous sinuses, and those arachnoid granulations oftentimes get blocked from these from the blood that's present there. So. And a question on what is the percentage of aneurysms treated open versus endovascular approach. In our particular center, we're sitting at probably 90% are treated via endovascular approach. And that's even higher when we talk about the subarachnoid population. It's probably closer to 95%. Just with the technology, the way that it's advancing on the endovascular side, it's really a nice minimally invasive approach. And those aneurysms that traditionally were thought to be really beneficial from a open surgical technique, the devices are becoming so good that they actually can treat, can be treated with an endovascular technique. So. A question from Dr. Ibrahim: drug of choice for high blood pressure and subarachnoid hemorrhage. I think in that acute setting, we often will use labetalol to try it. Now, labetalol, unfortunately, there was a worldwide shortage of labetalol, so we ended up having to utilize some other agents. We want to be a little bit cautious of ones that have vasodilatory effects. Things like nitro and hydralazine can have a little bit of this effect as well. So generally speaking, beta blockers in the first place was kind of the main we're trying. So. Yeah, and certainly, I think Dr. Reed is pointing out that, in different countries, there may be different, availability of different techniques. So, certainly, in much of the world, surgery is probably done still quite frequently. Hopefully, as device technology, coils at this point are really widely available. I think it's maybe more the infrastructure, whether we can actually offer endovascular therapies for a lot of these techniques. But certainly from a worldwide perspective, there's certainly a lot more open surgery still being performed for brain aneurysms. So considering a MISTI approach to evacuate blood in the lobar hemorrhage, any cutoff for blood volume. We will sometimes utilize, if we have a lot of blood contained in the ventricles. Volume wise, it's a little tricky sometimes to measure the exact volume of blood, because the ventricles, of course, can vary in size and shape and things. But if there's a good amount of blood, we will, and as you said, I think we don't follow the exact MISTI protocol, but use a MISTI-like approach where you can, through a ventricular drain, place about a milligram of TPA, close the drain for a period of time, and then drain off the CSF, and do that Q8H every 8 hours for usually about 24 to 48 hours. Fortunately, that technique is thought to be reasonably safe. We're not seeing that there's problems with increased bleeding with utilizing that technique. And certainly, if you have a large volume, and especially if your EVDs, we sometimes will use large size EVDs, large bore EVDs to try to help drainage. But even then, sometimes when there's a lot of blood products, it's useful to utilize a little bit of TPA to help clear those ventricles out and resume some flow within the CSF spaces. If there's other questions from the group. Another question around how to prevent cerebral vasospasm after after subarachnoid. There, I think the main things are, we know from the baseline, first of all, with the severity, how much blood is on that scan using the Fisher grade, what kind of risk the patient might have. Aneurysmal subarachnoid compared to other types of subarachnoid is higher risk for vasospasm. So once you get that aneurysm secured, keeping the patient euvolemic, increasing their blood pressure to running the patient hypertensive. Use of nimodipine, again, controversial. It can prevent the delayed cerebral ischemia, though. So use of nimodipine specifically. It is a calcium channel blocker, but other calcium channel blockers don't seem to have that same effect. And then monitoring those patients very closely, with some kind of not obviously clinical exam is primary, but if you do have the availability of transcranial Doppler, that can be a useful adjunct as well. So. I don't know if Dr. Sakur is on, if he wants to comment a bit on TCD. Dr. Sakur might have stepped away, so. I think the question here is whether it's useful to use mannitol in subarachnoid hemorrhage. Mannitol, we don't utilize it a lot, but although some patients do run into problems with severe cerebral edema, and so keeping the sodium level a little bit on the higher side of the range, probably in the 140 to 150 range, might be potentially beneficial. And in cases where there's impending herniation, the utilization of either mannitol or sometimes highly concentrated sodium solutions can potentially be a benefit as well. So. Yes, Dr. Khan's asking about the ENRICH trial. Dr. Bain at our center here is one of the lead investigators in the country for. They have recently wrapped up that clinical trial. It is being analyzed. So we don't have the results from ENRICH itself. However, in terms of minimally invasive ICH evacuation, we have been doing that here at the clinic for the last probably 7-8 years. I think there is potential and promise to this minimally invasive technique. So what they can do now is through a simple burr hole, they have different or very, very small craniotomy. They have devices that they can put down a small tube, help to then really remove the ICH, remove the clot from the brain, as well as they have access through there to be able to do all the things a neurosurgeon would normally have to be able to do if they have to cauterize a blood vessel or do other techniques. Removal of the blood, again, we have other clinical trials that of course been negative, but hopefully by refining it in the last last major trial, I believe it was Misty that was blanking on the name of it, but there it was showing actually that reduced volume, the more volume of the ICH that you could remove, potentially that could provide benefit to these patients. And so at least in our Cleveland Clinic data, when we look at it, similarly, if you can get to those patients and remove a good volume with these new devices where you can really remove most of that intraparenchymal hematoma, and particularly if it's in certain locations, if it's in the basal ganglia, not necessarily has already destroyed the internal capsule or the thalamus, those patients can actually have a pretty impressive recovery. So, of course, data still needs to be obtained. We'll see what the ENRICH trial shows, and there may be some other additional trials coming in the near future. So. Question around hyponatremia after SAH. Certainly hyponatremia can come from a few different reasons. One is with hyponatremia, you can actually end up with increased cerebral edema, so it's something that we want to be very mindful of. It also can be a reflection of cerebral salt wasting, and cerebral salt wasting itself, if not managed appropriately, can also create longer-term complications. So hyponatremia potentially makes it certainly a more complicated clinical course, and if it is developing, one has to be very, very aggressive with managing it in order to try to keep those sodium levels certainly in a normal range, and if possible, actually even a little bit on the higher side to avoid some of that cerebral edema. So. And a question around steroids for chemical meningitis. Steroids overall in subarachnoid hemorrhage haven't necessarily been shown to have a lot of clinical benefit. However, if someone has a lot of pain and discomfort, that blood products, especially if they track down into the along the spinal cord and irritate the nerve roots, can be very, very very, very painful. And so sometimes in those settings, the use of a bit of steroids can help to mitigate some of the pain that one is experiencing. So. Great. I think we might be coming close to time. I don't see any additional questions, but very, very nice to have the chance to talk to all of you guys.
Thank you a lot, Dr. Shazam. Thank you a lot to all. Thank you for this benefit lecture, and thanks to all to hearing. Thank you very much, Doctor.
My pleasure. Thanks for having me.